Thank you for joining us for the 4th Annual Global Summit on Kidney Innovations. Global Kidney Patient Voice, the Key to Accelerating Innovation, a collaborative partnership event presented by the American Association of Kidney Patients and the George Washington University School of Medicine and Health Sciences. My name is Catherine Campbell. I am an AAKP Board of Director and AAKP Ambassador for the state of Texas. I was diagnosed with kidney disease in 2016. I am proud to be engaged with KPMP, that's Kidney Precision Medicine Project, and TCRM work group led by Dr. Nickerson, who will be presenting today. Being part of AAKP allows me to learn more. Like I said, I'm a nurse, and of course I thought I'd already studied kidney disease, but AAKP has brought such great knowledge to the patients with videos, articles. You couldn't ask for a better research area on kidney disease. We're working with patients, medical professionals, researchers, medical industry allies to cultivate a new consortium led by patients. AAKP believes the international consortium can advance innovation and change kidney care in countries where healthcare systems are fractured, do not support patient consumer choice or access to care. For this session titled A Global Drive for Innovations in Home Dialysis, How Innovation is Facilitating Home Therapies, I am pleased to introduce friend and ally of AAKP, Mrs. Stephanie Silverman, who is CEO of Venn Strategies. Ms. Silverman joins us today to lead a panel discussion with some top dialysis advocates on the drive toward advancing and making available home therapies to more patients across the globe. I think that's going to be an interesting discussion. People are sometimes afraid, and this would be a good discussion why these individuals advocate for home dialysis. The first being Daniel Gallego. He's the president of the European Kidney Patients Federation, a former transplant patient and current home dialysis patient. Dr. Mallika, Associate Chief Medical Officer at Brigham and Women's Hospital and Assistant Professor at Harvard Medical School. And Dr. Vivekanand, Executive Director of the George Institute for Global Health and President of the International Society of Nephrology. It's an honor to have these exemplary visits from this panel. And now I'm going to turn it over to Ms. Silverman.
Thanks so much, AAKP and GW University, for having us here today. I'm Stephanie Silverman with the International Home Dialysis Roundtable. IHDR is a global forum of clinical leaders in home dialysis, kidney patient organizations, advocates, and industry partners who collaborate to identify and address global challenges and opportunities around access to home dialysis. I want to introduce all of you to my first guest, panelist Daniel Gallego, who is president of the Spanish National Federation of Associations for the Fight Against Kidney Diseases, ALCER. He has been in that role since 2018. He's also the president of the European Kidney Patient Federation since 2020, and he is a kidney patient since 1993. He's undergone hemodialysis since 1995. Danielle, thank you so much for joining us today for a conversation around global efforts to bring together patients and clinicians to promote access to home dialysis care.
No, thank you very much. My pleasure to join this interesting conversation.
Thank you. I'd like to talk to you a little bit about IHDR and your role since you've been involved so early on in the organization. Can you explain to me your thoughts about why it was important to become a member of the IHDR steering committee? The work that we do has really been about bringing the two communities, patients and clinicians, together. Why is that important to the European Kidney Patient Federation? What is the benefit to the organization that you're serving?
Yeah, I think, of course, AKPF participation in AHDR steering committee is critical because we need to address all the realities and bridge the gap about the unmet needs and of kidney patients and unpleasant symptoms or all the huge challenges that kidney patients are dealing with every single day, especially in dialysis and kidney transplant. So to be involved with all the stakeholders promoting home dialysis and as a first option, because nowadays home therapies are underused and underestimated. We strongly believe that chronicity should be managed at home whenever it's possible. So because home and family are therapeutic elements itself. So I think KPF is really focused to address the humanistic burden of the kidney disease. The humanistic burden involves health related with quality of life participation, daily life activities, and of course, health related of quality of life of caregivers and families. And we need to address this with all the stakeholders in this group. And I think it's a unique opportunity to exchange ideas, to exchange experiences and vision of the kidney patient all over the world in this steering committee with an amazing people that is doing their jobs and healthcare professionals and caregivers and patients together in this group.
Yeah, I think that's all incredibly important. So talk to us a little bit about what clinicians need to hear from kidney patients in order to understand how to best help them choose the right modality, including, of course, home dialysis.
Yeah, I think the key to empower people and patients is education, is not only information. So we need to give them all resource materials and time to ask and know all the therapies available. And patients, of course, should claim for the best option to adapt the treatment to their lives. So I think it's important to hear the patient stories and patient testimonials to exchange with the healthcare professionals. How is the reality, all the daily life activities with the burden of the disease. And I hope the healthcare professionals and caregivers learn from the patients this the burden of the disease and how challenging it is to live with chronic kidney disease, especially in the kidney replacement therapies as dialysis. So every single patient has a story to tell. And because we are survivors now, we are adapting our lives to the kidney disease with enormous time-consuming treatments, a lot of drugs, medication, and with heart restriction, and almost everything is forbidden. So it's not the same to know the path and that to walk the path. And health professionals know the path, but the patients, we are walking the path every day. So we are more than experts by experience. And I think to hear directly from the patients the reality and how to improve the home therapies for the patients, I think is the best opportunity in this IHDR group.
And through IHDR and other initiatives, then, what do you think clinicians assume is the case? And what realities do you think they hear that help them understand? What are the things that they haven't understood in the absence of patient voices?
I think the first thing is we are disqualifying the patients before choose, no? So it's not only for young patients, the home therapies. I think the first thing that they are hearing is for everybody who is able to manage the symptoms and to manage all the things to do the dialysis at home. So I think the first thing is to hear directly from the patients if they are able or not to do it. And of course, the percentage of patients that they are doing at home is very low in all the countries. And this is multifactorial, of course, but the first thing is we are disqualifying the patients before choose. So we need to increase the awareness about the home therapies, and it's a real choice, it's a real option for everyone. And another thing that they are hearing from the patients is with the home therapies, we have less restrictions of the diet and less restriction of the time to undergo the treatments at hospitals and dialysis unit. So the first thing is to improve the quality of life of the kidney patients through the real choice that gives you the opportunity to adapt the treatment to your life and not vice versa. And this is very important because we are celebrating everything by eating and drinking, and with less restrictions of the diet and less restrictions of the timetable, I think is a great opportunity to give them a better quality of life and better quality of care with these home therapies.
I really appreciate that. One of the interesting things about IHDR has been bringing together both clinicians and patients from around the globe. So as you listen to others in Europe, in Latin America, in North America, in Asia, in Africa, what are some of the patient similarities in those experiences, and what are the differences? How do patients on a global scale learn from each other in that kind of a forum?
Yeah. It is quite clear that we need to hear from worldwide, from all around the world, from every corner, how is the reality of the kidney replacement therapies, and try to understand why and how we could improve the reality to give them the opportunity to choose home therapies and home dialysis. This is only possible with this unique group in IHDR to exchange experiences and realities. And in my opinion, the information shared in this unit group with all stakeholders is giving the healthcare providers and policymakers a wonderful experience from the knowledge from the first hand of the kidney patients and professionals, and how and why home therapies should be developed and how should be the future of home therapies in the coming years.
So, Danny, you've been involved with AAKP and IHDR on international efforts related to kidney policy and research. And we know that EKPF is involved with AAKP in standing up an international consortium of kidney patients and innovation leaders to support the development of artificial organs. Can you tell us about the ideal role that patients will have in kidney medicine, broadly speaking, especially during this decade of the kidney?
Yes, of course. As kidney patients, as citizens, we are evolving from the only passive subjects to become a patient consumers with a very active role. This concept of patient consumer means one step beyond as individuals. We would like to start three important actions that really matters as kidney patients. Of course, the first one is voice. We would like to have voice on every single steering committee and the public health strategies with the policymakers on every decision, every plan. We would like to have this voice of the kidney patients. The second one, of course, is choice to enable a real shared decision making and to choose the better therapy or the better new therapeutics for the patients that you think is the best option for you. And the third one is co-production. Of course, we would like to co-produce materials and strategies and guidelines to establish the real concept of co-responsibility, because we would like to have a co-responsibility of our treatments, of our decisions. So this is because we are developing this international consortium of truly transparent and wide project to develop artificial organs without brands or royalties, trying to establish and to address the universal access of kidney replacement therapies worldwide. No, the estimations are more than 2 or 3 millions of people are dying every year without access to the dialysis. This is because we are trying to establish this international consortium with AAKP to develop this artificial organ without any price or without anything that is not giving the opportunity to the universal access to everyone worldwide. And of course, in developing countries, we have access to the dialysis, but in non-developing countries, the reality is that you will die in only a few days if you need a kidney replacement therapy. So we need to establish this international consortium to address the real matters, the real needs of the kidney people around the world, but not only in developing countries with money. So without any money, you have the right to access to the kidney replacement therapies, even in the non-developing countries,
where there are many, many challenges that the developed world, I think, hasn't really metabolized, right? One thing that's so interesting, I think, is the level of agency and advocacy by the kidney patient community in Europe, in North America. The notion of voice, choice, and co-production that you mentioned. Do you think that other countries, other regions are equally energized at the kidney patient advocacy levels? Are there disparities between the levels of opportunity to advocate for themselves in the kidney patient community between countries or between regions?
Yes, of course, the variety and the disparities of the access to the treatments and the knowledge about the disease of the kidney disease is huge. So this is because we are establishing or preparing capacity building programs for every kidney patients associations, organizations in Europe. AKPF is doing this job, trying to improve the skills of the patients to advocate better and more and better, to advocate with data, to be ready for the meetings and to be ready to establish a conversation with the policymakers, to claim everything that really matters to us, not only clinical aspects or not only economic aspects, but also humanistic aspects of the kidney disease that really matters to us. And this is the capacity building programs that we are establishing with AAKP and AKPF together, and try to improve all the kidney patients. I'm always saying that a good kidney patient is not a good kidney president. So I think we need to give them the education, information, and to advocate better and more all over the world with all the data and with claiming the best options for us.
So one of the recent projects you've been involved with has been co-publishing a paper in kidney medicine with Dr. Mallika Mendu and others, and we'll be talking to Dr. Mendu in a moment. Is it that kind of published material that helps to educate the patient community and make the patient and clinical community better connected? And what else do those communities need in order to stay and expand the connectivity that's needed to make sure that patients have opportunities to have the voice that you talk about?
Of course, papers and guidelines and technical documents are important because the information is available all over the world with Google. But we need to adapt these guidelines and these papers to the knowledge and the materials for patients, to understand better how is the medicine and the drugs and the treatments. And these adapted materials is what we are doing in AKPF or in the kidney patient organization. Try to translate the language to the health literacy for the patients and try to involve them with knowledge and with experience, and combining this experience with the daily life activities, and to try to to establish this co-production of material together. Even in the design of the clinical trials, we've been involved to improve the results and to include the patient report outcomes that really matters to us. And this is what we are doing more or less in our organizations to address our needs, with, of course, always adapting these materials, these papers and official and technical papers to colloquial language that everyone could understand and could develop some resource for every kidney patient all over the world.
So briefly, we have about a minute left. I wanted to ask you, one of the areas that you spend a lot of time in is working to eliminate policy barriers and bureaucratic procedures, especially for traveling on hemodialysis treatment. If you were going to ask policymakers on a global scale to take one critical step, and I know that you raised this in the IHDR paper in kidney medicine, what would that one step be across regions to make travel easier and to make access easier to home dialysis for kidney patients?
No, I think definitely home dialysis could be a solution for, especially for non-developing countries, to give them opportunity to have dialysis all over the world. So the first thing, of course, is the mobility, and travel is a right, even if you are in a kidney replacement therapy as dialysis. So because mobility is not only for leisure or for vacation. Mobility is when you are working, or you need to work to go abroad for a wedding or for another reason. So mobility is a right, and I think the dialysis without borders could be a dream, but we need to that this dream becomes a reality, because every single patient needs to travel abroad with a lot of benefits for everyone. And I think home dialysis could be the solution for the future, without water plants, without a facility, and you can do it easily. So we need a real portable machines and devices. And of course, the policymakers could facilitate all the bureaucracy, all the papers that you need to travel abroad for the kidney patients, and maybe with some card or some visa for the dialysis patient could facilitate this mobility as a right for every single kidney patient that needs dialysis all over the world.
I love the idea of dialysis without borders, Danny. Thank you for that, for all you do for IHDR and for the global patient community. It's a pleasure to be with you today.
My pleasure always, and please, joining forces is always the solution.
Absolutely. Danny, thanks so much. That was terrific. And having had a really important view from the perspective of a kidney patient, I really want to turn to a conversation from the clinical perspective. And we have two really exceptional guests with us today. So let me introduce you to Dr. Mallika Mendu, the Associate Chief Medical Officer at Brigham and Women's Hospital. She is responsible there for the transformation of care delivery at BWH to ensure the implementation of strategic priorities related to inpatient operations, care continuum management, and population health. She serves in the Department of Medicine and the Renal Division as a practicing nephrologist, a clinical researcher, and assistant professor, and she conducts research related to quality, population health, equity, and care delivery innovation. Dr. Mendu is also the representative of the American Society of Nephrology on the IHDR at our steering committee, and she's been deeply involved with the launch of IHDR's global efforts. Dr. Mendu, good morning and welcome.
Thanks for having me.
Thank you. And I know we have different panelists from different places in the world, so forgive me if I say good morning and good evening to different ones. Dr. Jha joins us from across the globe. Thank you so much, Dr. Vivek Jha, for joining us today. He is the Executive Director of the George Institute for Global Health, India, the President of the International Society of Nephrology, the chair of Global Kidney Health and the Faculty of Medicine at the Imperial College of London. He is a recognized global expert on kidney disease and focuses on emerging public health threats globally and, of course, in India. He has been deeply involved also with IHDR as the representative of ISN at our steering committee level and as a founder of our efforts as well. Good evening, Dr. Jha.
Hello, thanks for having me.
Thank you so much. I want to get right into it. It's the decade of the kidney, and I think we want to hear your perspective, both of you, having both been heavily involved in AAKP and IHDR. We know that you both appreciate both organizations' shared and independent experts to expand patient engagement and involvement in kidney research and innovation. Would each of you share your reflections on what you consider the importance of expanding the involvement of patients in policy and innovation worldwide? Dr. Mendu, can we start with you?
Yes, thanks for the question. It's such an important one, and it is, in fact, been the decade of the kidney. And really because we are hearing patients' voices loud and clear, and their stories are really resonating. I would credit that because of two things. First, the COVID pandemic, and witnessing the significant impact of COVID on our patients with kidney disease. So that's patients who have chronic kidney disease and are at risk of developing the need for kidney failure. And that's our patients also with kidney failure who are either getting in-center dialysis or home dialysis, or our patients with transplants and the fear of getting COVID because of being immunocompromised. And so what COVID revealed is how vulnerable our patient population is, the disparities that we previously saw with kidney disease were expounded by the COVID pandemic. And the COVID pandemic really made the case for home dialysis because it facilitated the ability to distance during crucial periods of the pandemic, particularly during wave 1, wave 2, and this impacted different parts of the world at different times. And so COVID was a major factor, and because we had the world's attention in terms of the impacts on healthcare, many of our kidney patients' voices were amplified during that period. The second is that there has been a sea change when it comes to home dialysis that may be somewhat attributable to some of the efforts in the United States around what we call the Advancing American Kidney Health Initiative. This is an initiative that was started during the Trump administration with an executive order, which basically outlines a goal of 80% of patients being on home dialysis or transplant by the end of 2025. And though this was a United States focused effort, it did have implications for other countries to say that the United States, which has lagged in home dialysis rates, is doing something really meaningful in terms of facilitating home dialysis, and there are lessons to be learned by other countries. And so the Advancing American Kidney Health Initiative really was spurred again by patients' voices, by patients' stories, to say that this is the time to provide more resources, to provide more direction, to align patient goals and patient preferences with provider and system preferences and goals. So I would credit both of those two factors. And I think it's very encouraging that patients' voices are being heard in this space.
Thanks so much. Couldn't agree more. Dr. Jha, picking up where Dr. Mendu left off, the impact of patient voices has obviously been felt in the United States and globally. What more do patients need to be strong and effective advocates for their own interests in the context of access to home dialysis and any modality of care that they require?
Thanks. I'm so glad that you started with that specific question, because in the last few years, we have increasingly understood the importance of taking the perspectives of people who are living with the disease when deciding what we do for them and with them. And this has come from not too far ago from the HIV pandemic, when the call came from the patients with HIV, nothing for me without me. And that's something which has slowly spread to other health conditions as well. And people with lived experience, they have their own life goals. And it is really important that we listen to their voices in deciding their treatments, whether it is care delivery or it is research. We have a number of initiatives both in United States and elsewhere in the world, one of which is the most important SONG initiative, in which we nephrologists around the world and researchers are trying to understand what is it that the patients value as the most important outcome measure. And this exercise has really made us very humble, because we recognize that what patients prefer is not always the same as what healthcare providers think to be important. And so we slowly recognize that we need to increasingly form partnership with patients when discussing their issues, developing plans that impact them directly, and developing models of care. Because ultimately, whatever the patients are looking for, we should be able to provide that. This also requires us to be flexible and pragmatic, because although a number of things are linked to the healthcare system, but within the perspective of those healthcare systems, it is possible that we can modify the care which meets the personal goals of individuals. So patient engagement, or consumer engagement, as we call in different parts of the world, becomes a nuanced affair where we engage with the community, but we also, as we go deeper down into it, we start engaging with individual patients, their families, and it requires us to understand their social circumstances, their family perspectives, etc. And Dr. Mendu did provide you with the reasons that has made us humble and increased our realization of why patient perspectives may be important and why do need to be attentive all the time to listening to those perspectives. It's important to mention also that patient perspectives are not fixed and they might change from time to time. We should be responsible and responsive to that kind of a change by adjusting the way we deliver care to them. So this is a growing field, and how do we empower them to make sure that their voices are heard? The first thing is to just for us to give them that reassurance that we are there for them and we are willing to listen to them, by inviting them to become equal partners in care decisions, such as shared decision making, and also during development of research projects. So involving patients as partners in research programs is also important, and we are increasingly doing it in our programs as well as others as well.
Thank you so much, Dr. Jha. Dr. Mendu, the IHDR First Summit, which brought patient voices from around the globe together in a virtual format. It was right in the early days of COVID, right? With clinician leaders, with innovators, with other advocacy organizations, led to the identification of patient empowerment, but other initiatives that the group believed would be most important to advancing access to home dialysis. Can you talk a little bit about the 4 pillars that emerged from that conversation, which then became featured in an article that you spearheaded in Kidney Journal, in Kidney Medicine? I think it would be helpful to contextualize the patient empowerment element with all of the other pieces that we've been talking about to understand how they all come together. Can you talk to that?
Absolutely. Yes. What you're referring to is a very seminal moment, I would say, in terms of the international home dialysis and kidney community coming together and outlining action areas for us to collectively be able to move forward home dialysis care, where candidly, there has been very slow growth in this area since the inception of dialysis 80 years ago. And so the feeling, the sentiment at that time during that roundtable meeting was, now is the time. If we don't do this now, if we don't have this call to action now, how are we going to be able to advance this field? And the reason for the now was that if you look at the timing of our home dialysis roundtable, it was during the height of the pandemic that we started organizing and bringing these various groups together And as you emphasized, it was the patient's voice that everyone wanted to hear, that was really central to the conversation and central to the guidance around what are the key pillars that we need to develop in order to say this is a foundational infrastructure to promote and foster home dialysis. And so number one that we outlined was patient empowerment and education, as you mentioned. And really key to that is to say we have a cohort of patients who have not traditionally been had the access to, for example, campaigns, social media that other groups have. I think Dr. Jazz mention of the HIV community is entirely appropriate in drawing the parallel there. And the question is, why have we not been able to make those types of strides in many cases? And one of the areas that we identified is really ensuring that we provide the resources, the infrastructure to empower this incredibly meaningful, knowledgeable patient group. So providing resources around social media, patient-centered events in collaboration with important patient-led organizations. The development of country-specific modules for patients, for clinicians, and understanding that there are areas where country specificity is important, that there are cultural sensitivities, there are going to be economic and some disparities that need to be addressed in particular countries. And so that was a key part of that element. And then focusing on those patient stories, promoting those patient stories, and making sure that patients are involved in terms of planning, whether it's policy, whether it's educational efforts, whether it's campaigns. So really want to emphasize the patient empowerment and education pillar. So that was pillar number one. The second pillar was around international standards and cooperation. And really that was to say that we need to organize across the nation. And obviously we've had organizations like ISN and other organizations that are been critical to organizing groups of nephrologists, patients, advocates. But this is taking it a step beyond to say we need standards across countries. We need to leverage shared advocacy efforts, shared policy efforts. We need to think about where we can standardize, whether it's education or training or materials to promote access to home dialysis. So it's really the word I'd emphasize there is standards and making sure that there are true global standards. The third pillar is around a culture of support for home dialysis. And I think this makes sense. This is really the common thread throughout all of the pillars, but to specifically call out the culture of support because of the fact that for so long, home dialysis in most countries has not been the status quo. And so in order to really advance home dialysis, the culture needs to change. And that culture change has to include patients who are the strongest advocates for their care, but also needs to involve clinicians who traditionally in many countries have been oriented towards in-center hemodialysis. And so leveraging our global organizations again, many of whom have been very successful in terms of fostering home dialysis in certain countries, and bringing our clinicians along, whether that's through education, whether that's through peer mentorship, and ultimately involving home dialysis patients to be the connecting thread between all of those groups. And then the fourth pillar is around mitigation of institutional or governmental roadblocks. And so what we mean by this is calling out those specific areas where there are candidly roadblocks that have been put into place, many of which are unintentional, are just the ramifications of long-held practices of how we paid for dialysis or the infrastructure around dialysis. And so, for example, the peritoneal dialysis catheter access is a very good example of that, is that inadvertently there are barriers to peritoneal dialysis catheter placement. And we need to look at things like incentivization, like training programs to truly promote the use of catheters and catheter placement. And look at things like how payment policy, health policy in many of these areas, and truly to engage with our health policy experts and government experts in many of these areas. In some countries, kidney disease is a focus. In other countries, it may not be a focus of these governments. And so educating these governments about the roadblocks and then coming up with solutions and being solution oriented around what some mitigation strategies would be. So that summarizes it. And I would end with saying that this is really a framework, a roadmap that we put into place. And subsequent to publishing this, that's when the work has truly begun to say, now we're going to take this roadmap and we're going to operationalize this. We're going to work with patient groups. We're going to work with advocates and clinicians to make these pillars a reality.
And it's a big task, but A, very important one, and B, I think one that's already being operationalized by you and Dr. Jha and the leaders of IHDR and AAKP, both together and independently. Dr. Jha, you recently published a paper in Clinical Kidney Journal on the very topic that Dr. Mendu referenced on peritoneal dialysis catheter access, and notably patient voices like Danny's involved in helping to think through and prepare that submission. How do patients need to think about PD catheter access as we're emerging from COVID, and how do clinicians need to think about that differently in order to address what has become a real stumbling block, particularly during the pandemic?
Peritoneal access or peritoneal dialysis catheter is really the lifeline for patients who are going to be on long-term peritoneal dialysis. If not done properly, this can also become their Achilles heel. And so we need to understand that, and no one understands the importance of having a good functional PD catheter than patients themselves. They check it every day, they worry when something doesn't work properly. And let me personalize a little bit by telling you my personal experience. When I started a PD program in my institution more than a quarter century ago, the first thing that became apparent is that we needed someone to put in the PD catheter, and we needed to identify that champion. And indeed, it was I who, along with a colleague in one of my surgical divisions, who learned how to put in the catheter, and we became partners and put in PD catheters together in first 100 patients before expanding it. So that came home as really a critical element in a patient's journey on getting peritoneal dialysis. So having said that, it is important to emphasize that a PD catheter access starts even before the patient is going to start on dialysis. It starts with education. It starts with us, healthcare providers, sharing the patients the importance of peritoneal dialysis catheter, identifying the most important type of catheter, how the catheter will be inserted. There are a number of methods which can be used, and one method may be more appropriate for one type of patient compared to another one which would be more suitable for someone else. So we need to have that discussion with the patient so that they are comfortable, they understand the pros and cons of various methods for putting in PD catheter. But the question will be asked, can we do all of those methods in every single hospital? So the answer is clearly no. I think we have to rely on the expertise that is available locally, and not all catheter insertion type expertise will be available in all hospitals. So therefore, we also need to discuss that with the patient so that expectations are managed appropriately. The question is often discussed in the kidney health community: who puts in the catheter? Again, we need to be really pragmatic there, and we need to go with locally available resources, locally available talent. In many institutions, it is a surgeon who puts in a peritoneal dialysis catheter, but surgeons are very busy and they have many other priorities because they are not the primary caregivers to patients with kidney failure. It is the nephrologists who have been taking care of these patients for years, perhaps before they develop kidney failure. And once the patient starts peritoneal dialysis, they will keep coming back to the same nephrologist. So it is the nephrologist who understands more the importance of the PD catheter for the patient, and it is most appropriate if the nephrologist also gains the skills to put in the PD catheter. And that movement is growing around the world. In many low resource areas where even nephrologists are relatively scarce, it is a nurse who can become the primary caregiver and will learn to put in the PD catheter. And the International Society of Nephrology has a program called Saving Young Lives, in which nurses and other type of non-physician healthcare workforce is trained to put in peritoneal dialysis catheter, and thereby they are able to save the lives of hundreds of thousands of people with kidney failure. This has mostly been done for acute kidney failure, but there is no reason it cannot be expanded to include care of patients with chronic kidney disease as well. We need to identify and discuss the various barriers and facilitators with our patients. These barriers could be sometimes regulatory barriers. For example, some jurisdictions might specify who can put in a PD catheter, and there we need to work with the patients to sometimes identify if there are any roadblocks. For example, if the regulation says that only a surgeon can put in a catheter and there are not enough surgeons available, then patients can form an advocacy group and lobby for changing that regulation with the government or the policymakers. There could be institutional barriers. For example, where can a PD catheter be inserted? Should it be inserted always in operating theater, or can it be done outside the operating theater also in an appropriate sterile environment, because operation theater space may not always be available? And the third set of challenges that patients might face, which may delay their peritoneal dialysis catheter insertion, is logistic challenges related to availability of disposables and the other type of workforce that I described. Therefore, consideration of local resources is critical, and we must tailor our program to suit the locally available resources. This was helped by a survey that we conducted as a part of this paper, in which we identified specific barriers and then suggested possible solutions that could be used to overcome those barriers. And so there are a number of actions that came out of it, which made us identify these specific steps, which were related to awareness of the feasibility of peritoneal dialysis in a given situation, training in access insertion. As I said right in the beginning, training is important. I have myself identified that as a critical component and had to undergo training myself. And now that we have recognized that peritoneal dialysis care provision is not just the job of a nephrologist, development of multidisciplinary teams, a team of surgeon for insertion of catheter in someone who is not suitable for the type of insertion that can be done by a nephrologist, such as percutaneous insertion. I think we need to have them on standby. We need to also have appropriate PD nurses ready. We need to be able to share the advantages of peritoneal dialysis with our patients and impress those advantages upon our policymakers, because peritoneal dialysis carries a number of advantages to the healthcare system by developing appropriate information and education materials. For many healthcare systems, these need to be coupled with reimbursement reforms as well, as to how can appropriate PD catheter insertion be appropriately incentivized. As I said a moment ago, pre-dialysis education for the patients is extremely important, because it has been seen that in absence of such an education, when patients sometimes present precipitously to an emergency room situation requiring dialysis, hemodialysis, which is not necessarily best for them in the long run, becomes the default choice, and the patients then are reluctant to come off it. So therefore, it was really instructive for us to be working to put together this paper, because we were able to identify all the possible challenges that the community faces, including the patient community, and we're able to suggest solutions which will go a long way in helping those units or those jurisdictions that are planning to set up sustainable peritoneal dialysis programs to take care of those barriers upfront and put in place solutions that are appropriately responsible and responsive to local resources.
The work on both of these papers has been fairly extraordinary, both in terms of their reach across the globe and the importance to patients themselves as resources. And I just want to say, as we close out this panel, in addition to my thanks to Doctors Mendu and Ja for their tremendous work in this community, in recognizing and forging this collaboration between the clinical community on a global scale and the patient community with our partners at AAKP and others. I also want to note that Dr. Ja and Dr. Mendu both are involved in the creation of a digitally accessible compendium where these and other resources will be available, so that the work is not done in a vacuum in small rooms and small huddles where we talk about challenges and then don't figure out how to operationalize those challenges, including by getting those resources and information to the patient community. So thanks to both of you. Thanks to Danny for his important insights on behalf of the patient community. Thanks to AAKP and GW. We really appreciate the opportunity to talk about IHDR and, more importantly, the work where clinician leaders like Drs. Ja and Mendu are bringing together the patient community to promote more accessible solutions to home dialysis on a global scale. Thanks so much.
Thank you, Mrs. Silverman, for leading such a wonderful discussion on efforts to ensure home dialysis has borders and that all kidney patients have choice and access to the treatment that best suits them, their care plan, and aligns with their life goals and aspirations. We truly appreciate all speakers sharing their time with us.